Approach to the humerus. Operations on the humerus are relatively infrequent and generally involve the open reduction and internal fixation of fractures. All approaches of the humerus are potentially dangerous because the major nerves and vessels at this site run much closer to the bone than they do elsewhere in the body. The axillary, radial, and ulnar nerves all have a direct relationship to the humerus. 4 approaches to the humerus are described. The anterior approach. The anterolateral approach to the distal humerus. The posterior approach. And the lateral approach to the distal humerus. Of these, the anterior and posterior approaches are the most versatile, providing access to large portions of the bone. The anterolateral approach to the distal humerus is extensile both proximally and distally. Anterior approach. The anterior approach exposes the anterior surface of the shaft of the humerus. Normally, only a portion of the approach is needed for any of the procedure. As in all approaches to the humerus, the radial nerve is the structure at greatest risk during surgery. The uses of the anterior approach include internal fixation of fractures of the humerus, osteotomies of the humerus, biopsy and resection of bone tumors, treatment of osteomyelitis. Position of the patient. Place the patient supine on the operating table, with the arm on an arm board, abducted about 60 degrees. Tilt the patient away from the affected arm to reduce bleeding. Most surgeons prefer to sit facing the patient's axilla, with the surgical assistant on the opposite side of the arm. Tourniquet should be avoided as it only gets in the way. Landmarks and incision. Landmarks. Palpate the coracoid process of the scapula immediately below the junction of the middle and outer thirds of the clavicle. Palpate the long head of the biceps brachii as it crosses the shoulder and runs down the arm. The lateral border of its freely moving muscular belly lies on the anterior surface of the arm. Incision. Begin a longitudinal incision over the tip of the coracoid process of the scapula. Run it distally and laterally in the line of the deltopectoral groove to the insertion of the deltoid muscle on the lateral aspect of the humerus, about halfway down its shaft. From there, the incision should be continued distally as far as necessary, following the lateral border of the biceps muscle. The incision should be stopped about 5 cm above the flexion crease of the elbow. Internervous plane. The anterior approach makes use of 2 different internervous planes. Proximally, the plane lies between the deltoid muscle, which is supplied by the axillary nerve, and the pectoralis major muscle, which is supplied by the medial and lateral pectoral nerves. Distally, the plane lies between the medial fibers of the brachialis muscle, which is supplied by the musculocutaneous nerve medially, and the lateral fibers of the brachialis muscle, which is supplied by the radial nerve laterally. Superficial surgical dissection of proximal humeral shaft. Identify the deltopectoral groove using the cephalic vein as a guide. And separate the two muscles, retracting the cephalic vein either medially with the pectoralis major or laterally with the deltoid, whichever is easier. Develop the muscular interval distally down to the insertion of the deltoid into the deltoid tuberosity and insertion of the pectoralis major into the lateral lip of the bicipital groove. Take care when retracting the deltoid. Overzealous use of the retractor may paralyze the anterior half of the muscle by causing a compression injury to the axillary nerve. Distal humeral shaft. Incise the deep fascia of the arm in line with the skin incision. Identify the muscular interval between the biceps brachii and the brachialis. Develop the interval by retracting the biceps medially. Beneath it lies the brachialis, which cloaks the humeral shaft. Deep surgical dissection of proximal humeral shaft. To expose the upper part of the shaft of the humerus, incise the periosteum longitudinally just lateral to the insertion of the tendon of the pectoralis major. Continue the incision proximally, staying lateral to the tendon of the long head of the biceps. The anterior circumflex humeral artery crosses the field of the dissection in a medial to lateral direction and must be ligated. To expose the bone fully, may need to detach part or all of the insertion of the pectoralis major muscle from the lateral lip of the bicipital groove of the humerus. This must be done subperiosteally. If you need to dissect further around the bone, the dissection should remain in a strictly subperiosteal plane to avoid damage to the radial nerve, which lies in the spiral groove of the humerus and crosses the back of the middle third of the bone in a medial to lateral direction. Distal humeral shaft. Split the fibers of the brachialis longitudinally along its midline to expose the periosteum on the anterior surface of the humeral shaft. Incise the periosteum longitudinally in line with the muscle dissection and strip the brachialis off the anterior surface of the bone. Try to preserve as much soft tissue attachment as possible.